Okay, so the first topic that we are going to talk about is going to be acute coronary syndrome. And we're going to start talking about the whole topic starting from stable angina. Okay, but before we start, I wanted to start with something that I think is going to set you up for learning in general. So, whenever you learn about any condition, and in this case for cardiology, you're going to see a lot of chest pain. When you do respiratory, there's going to be a lot of chest pain. So, whenever you learn about a condition, and in this specific case about chest pain, know the features. And by that I mean symptoms, okay? So, how does the pain of a stable angina differ from the pain of unstable angina, differ from the pain of costochondritis, differ from the pain of, let's say, pericarditis? In your mind, whenever you see a pattern of a description of a chest pain, you need to kind of get an idea of what it is. Sometimes it could be ambiguous, but most of the time you can tell from the clues in the question stem. So my very first step, which is why I didn't need your role to pass the exams, was for every condition that I studied, I did the features or the symptoms. I knew the specifics of, let's say, chest pain. Let's say we're talking about chest pain. I knew the location. I knew where it radiated to. I knew things that made it worse or better. And I also, let's say we're talking about stable angina, for example. Not only did I know the features of stable angina, but I also knew features of similar conditions that could look like stable angina. For example, let's say it's pain from GERD. Sometimes they say there's epigastric pain and the patient feels like they can't walk because there's so much pain, but then they miss certain characteristics of stable angina and it hints towards some other cause of chest pain. The point is, for every condition, know how the symptoms are worded. And most of the time, you could either get this from UWorld, or you could use a review book like White Coat Companion, or you could use AI now that we have AI. But know the features and know how to differentiate them from very similar conditions. Because on the exam, you're going to be asked one of three things: diagnosis, best next step of either diagnosis or treatment. Okay? So what I do, learn the features, and then I learn the diagnosis step by step, starting by step 1, move to step 2, move to step 3, and same thing for treatment. And you'll see how I do this with the conditions that I'm going to talk about today. This is how you should approach every single condition that you study. And if you do that, there's only so many that they can ask you that you don't know. So let's get started. This was just kind of a general advice, but we're going to talk about the first thing, which is evaluation for suspected acute coronary syndrome. This is not really testable, quote unquote, but then it's going to set up the framework of how you're going to think about someone with chest pain. So the first thing that you're going to do if someone shows up with chest pain is going to be doing a initial ECG with troponins. And you're also going to administer aspirin and nitroglycerin because the threshold for suspecting an MI should be very low in general, because some people, they're not going to present with a very classic MI presentation. They could just have epigastric pain. They could just have jaw pain. Some people don't even have pain. And so it really depends. And so your threshold for ordering this and giving this should be very low. Most of the questions you're going to come across, they will already tell you that there's an initial ECG. They're going to tell you if it's abnormal or normal. They're going to tell you that they order troponins. So most of the time they're not going to ask you to do this, but let's say you're reading a question about chest pain and they haven't done the initial ECG or the troponin levels, then you know that's going to be the very first step you do. So here is a diagram that I got from UWorld, and you're probably going to come across it when you do questions, but let's say you did right here, you did your initial ECG and troponins. You're going to get one of three results. One is going to be completely normal right here. That doesn't mean that your patient doesn't have ST changes. So what you do to be extra careful, you're going to order serial troponins and ECG, which is right here. Because sometimes the patient hasn't had the MI for too long, and so their troponins are normal, their ECG hasn't made the changes yet, so you can just do serial troponins and ECG. Now, if it's positive, at some point you start seeing elevated troponins or changes on the ECG, then you admit them. And then you start the STEMI algorithm that we're going to discuss in a little bit. If, let's say, the patient has chest pain, but the troponins are negative, the ECG is negative right here, that doesn't mean that the patient is healthy, because they still presented with a chest pain right here that made you think, hey, this could be acute coronary syndrome. So you send them for a stress test. And we are going to discuss this in more depth in a little bit, because sometimes they ask you what type of stress tests you want to order. Okay. The other option that you're going to get is that you see ST elevations or a new left bundle branch block. These are both meeting the criteria for STEMI, so you admit them and start the STEMI algorithm that we're going to discuss in a little bit. Let's say your patient gets elevated troponins without ST changes, or simply random ST changes that are not essentially ST elevations. You still admit, because you want to figure out, why is this patient getting elevated troponins? Why is this patient getting random ST changes? You still want to admit. So basically, at the end of the day, either you're getting abnormal ECG and then you do admission, or it's normal and then you do serial ECG and then you either admit or you do a test. Kind of, that's what they're saying right here. This is just a framework to think about when you're doing questions that have to do with chest pain in general. So now we are going to start with stable angina. And just keep in mind what I said earlier. Whenever you learn about any new condition, not just in cardiology or respiratory, in every single condition that you study, know the features, the characteristics, and how it's worded. So for stable angina, we're going to have a predictive. I underlined it, I highlighted it, because this is very high yield to know, and because sometimes they would say something like, oh, this patient had a history of 1 year of stable angina. Okay, but 3 days ago, this chest pain happens at rest. Suddenly, this pattern right here, it's no longer predictable, so this is no longer stable angina. This became unstable angina. Okay, so the point is, be very careful with the words, be very careful of how they present it, because how you treat stable angina is very, very different from how you treat unstable angina. We treat this like we treat an MI, and this is going to be more long-term medications. So this is just kind of to reiterate the importance of being careful with the description. Pay every detail to how they describe the symptom. So we have a predictable pattern of chest pain, and this chest pain is not sharp. It's going to be pressure, tightness, heaviness, squeezing. It's just this heavy pain that's predictable when you do any exertion or activity. And by exertion, this could be just being emotionally stressed, or it could be, you're crying. It doesn't have to be moving around. And it's relieved with rest or nitroglycerin. This is very high yield for stable angina, because we're going to go to a table down here where you start figuring out if a pain is angina pain or it's not angina pain. And that's going to determine your pretest probability, and it's going to determine if you're doing a stress test in the first place. So, predictable pressure tightness with exertion or activity relieved with rest or nitroglycerin. And it's also very important to know that there are no symptoms at rest and there are no troponin elevations. Because if troponins are elevated, it's unstable angina. Okay? So, and then also make sure that the patient kind of matches the symptoms. These are usually old patients and have multiple risk factors for coronary disease. If you have a 20-year-old, let's say, and they don't have a history of anything, they're most likely not going to have angina. You're going to have to look at other causes. And so another tip for questions, whenever you're doing a question, look at how old the person is. Look at their associated risk factors. So here we have predictive pressure, squeezing, pain, increases with activity, improves with rest or nitroglycerin, and it's an old patient with multiple risk factors for coronary disease. Remember this, because sometimes you're going to get questions that sound like stable angina, but you're missing one of the key descriptors here, and it's going to point you to some other cause of chest pain. So, right here I drew this stupid drawings. It kind of reminds me of the symptoms of stable angina. 1 is predictable. It's not going to come randomly. You know when it's going to come and bother you. 2, it's relieved by rest or nitroglycerin. 3, triggered by exercise or stress. And then 4, it's going to be pressure, squeezing, heaviness type of pain, and it's going to be substernal, which means literally all it means is this right here. I drew this boulder right here because this is going to be like a crushing chest pain, and this heart is running to remind you of exercise. This is supposed to look like a sternum. It's kind of blurry because it's substernal. This is a rest area with medications because it's relieved by rest and nitroglycerin, and this is to remind you that it's a predictive pattern. This is important. Why? Because we're going to talk about what atypical angina pain is and what atypical pain is and what non-anginal pain is. So this is all going to make sense at the end when we talk about the pretest probability, which is going to tell you if you need to do a stress test. Okay, so this is all leading to this, but we're not going to get ahead of ourselves. We're just going to be here. So atypical angina pain, okay, is going to be something substernal and is going to have the same quality and duration. The quality is going to be the crushing substernal pain, okay, and the duration is going to be less than 30 minutes. And it's provoked by exercise or emotional stress, and it's relieved by rest or nitroglycerin. Okay, so this is what a angina pain is like. You need to have all three for it to be angina. In order for it to be considered atypical, you get 2 of the 3 characteristics that we listed here. If someone comes in and they have a substernal chest pain that is provoked by exercise, but it's not relieved by nitroglycerin or rest, it's not angina. It's atypical presentation. And if it's just less than 2, meaning you only have one of these right here, it's just not angina at all. Not even atypical, it's just not angina. Go look at other causes of chest pain. So when you're studying for the internal medicine shelf exam, memorize this table, memorize what it means for it to be angina, memorize what it means for it to be atypical, and what it means to be non-anginal. And remember this photo right here to kind of give you a visual to remember, okay? So why does this classification matter? Because it's going to help us determine the pretest probability. If someone has a low pretest probability, they don't get any treatment. No treatment, no more testing. And we're going to talk about what a pretest probability is. I'm going to show you what it is. I'm just going to tell you before we even start what it means. Most of the time though, in questions, you're going to be somewhere right here. You're going to have intermediate probability. For these people, they get a stress test. Someone who has a high probability, you go straight up to coronary artery disease treatment. This just means that they have, they're most likely having coronary syndrome, and you need to treat them given them medications. But if it's intermediate, you're really not sure if they have coronary disease. So you do stress testing to figure out if they have it. Okay, so who has a low probability of coronary disease? It's going to be asymptomatic people of all ages. Okay, so you and I, we have low probability. We don't need treatment, we don't need testing. And then also people who have atypical chest pain, and they are women who are under 50. And this is why we talked about what it means to have atypical chest pain, because atypical chest pain is going to be this right here. You're going to have angina-like chest pain that doesn't meet all the requirements. You're only going to get one of these, or two of these, I'm sorry. Okay, so right here, I drew 3 hearts. Again, it helps with seeing something visual, especially on exam. The smallest heart, this is going to be the low probability people. Okay, and right here, it says no additional testing because the probability of them having coronary disease is very low. And who are the low probability people? Women under 50 with atypical pain, or all asymptomatic people. You don't do anything for those people. Most of the time, like I said, you're going to be here. Okay, most of the questions are going to be here. And these are people with intermediate probability. And because you are not really sure if they have coronary disease or not, these people are going to get stress testing. And this middle one, you can tell he's very stressed. He's very stressed about his test, like we are. So they're going to get stress testing. And who are the people that have intermediate probability? It's going to be men of all ages who have atypical pain, and women who have atypical pain but they're older, 50 plus, or they have the typical angina pain but they're 30 to 50. And I'm going to make sure that these drawings are clear when I send them to you so you can refer to them. And then of course the biggest heart right here, he's the oldest guy. He's getting empiric treatment for coronary disease. And who are the people that have a high probability? It's going to be just older people, women who are 60 plus with typical angina pain, or men who are 40 plus with typical angina pain. So for me, the way I remember it is that the high probability group is going to be the typicals. Typical men, typical women, and it's going to be 40 plus for men, 60 plus for women. And when I say typical or atypical, we're going back to here. Classic is going to be typical, atypical, and then non-anginal. So this right here is going to be very important to memorize. Memorize both tables. Memorize when it is that you have a patient in this category right here, because this patient gets a stress test, okay? And it's going to make more sense as we go because you're going to see how it all comes together. Okay, I'm going to erase all of this right here because it's kind of becoming a mess. Okay. So just know that these tables understand plus memorize. Okay. So this is kind of going back to, we said low probability. These are going to be these people right here. We said this is not angina because they are asymptomatic, either asymptomatic right here, or they have atypical chest pain in a young woman. These people, they're not going to have coronary disease. And then intermediate, which is, this is the one you want to know, because a lot of times they just ask you to choose the type of stress test. And I'm going to see if I can find the table here to show you types of stress tests. Okay, so let's say someone comes in, they have an intermediate probability of having coronary artery disease because it's either a woman who is 50 plus with atypical angina pain, or a woman who is 30 to 50 years old with typical angina pain, or it's a man with atypical pain who's at any age. Again, this is something you want to memorize. Put it to your memory because you don't want to be thinking about these numbers right here on a test, okay? But let's say you're right here. This is your patient, okay? And you need to do a stress test, and the question is asking you to choose the type of stress test. This is gonna be, at first when you look at it, it's gonna look a little annoying, but it gets better when you see the table. So you have, let's see if I can find the table right here. Okay, so here we calculated the pretest probability, okay? We said that low people, they don't get any additional testing. High people, they get the pharmacological therapy for coronary artery disease, and you send them to a cardiologist. In the question stem, your patient is right here, and you need to do a stress test. And the type of stress test is going to depend on two things. It's going to depend on ability to exercise and their baseline ECG that you did in the very beginning of this lecture. Okay, so are they able to exercise? If they can exercise, they will have an exercise ECG. Okay, I'm gonna put it right here. Able to exercise. We're gonna do exercise stress test. Okay, but there's two types of exercise stress test. There is a exercise with no imaging, or exercise with imaging. Okay. If your patient is able to exercise right here, you already know it's going to be an exercise stress test. But if it is someone with a healthy baseline ECG, you're going to do no imaging because they have their normal ECG. They don't have any abnormality. You just give them the good old exercise stress test with no imaging. However, let's say their baseline ECG has an abnormality. The exercise ECG that you're going to do is going to be with imaging. And we're going to talk about the imaging type. We're going to talk about the pharmacological stress testing in a little bit. But just know, right here, can you exercise? Yes. Then is your baseline ECG normal? Let's say it's yes right here. Then you just do the good old exercise test. Let's say you're able to exercise. However, you have an abnormal ECG right here. You still do an exercise test. However, you just add a little imaging test to it. Because if you don't do an imaging test and their baseline ECG is abnormal, then it's going to be very hard for you to tell if the changes on the ECG that you're doing is because they have a pathology or because they have an underlying cause from the beginning in their initial test, if that makes sense. You can't really tell if they have coronary disease or not if you start out with an abnormal test. Okay? Let's say that they cannot exercise. Maybe they are paraplegic, or maybe they have a condition where they can't move. Any condition that you can think of, they're wheelchair bound. You do a pharmacological stress test with imaging. Always, always imaging. It's not going to be alone because you need to image the heart. Okay, we're going to go back a little bit because I want to discuss this in depth so that way you kind of know how to go about stress testing. Here, we're going to discuss this in a little bit, but first I'm going to go up there, look at the notes so we can go over it. We said that most of your patients are going to be intermediate probability, and you need to do a stress test and you need to choose the stress test, okay? And then you either have exercise stress testing or you have a pharmacological stress testing. Exercise stress testing is for anyone who can exercise, but then we said one is no imaging, just exercise ECG, and this is for healthy baseline ECG. Or you do with imaging if abnormal baseline. Okay. And when I say abnormal baseline ECG, the very initial ECG that you get, we're talking about a left bundle branch block. They're using digoxin because digoxin causes ST scooping, so that can hide pathology. Or you have left ventricular hypertrophy with strain. Usually this would be mentioned in the question. This would be mentioned in questions. This would be mentioned. This could just be a list, part of their medication list. And then and this could also be mentioned in the question. So you don't really need to figure out the abnormality by looking at a strip. They're going to tell you something. But if you see this mentioned somewhere, then you know that baseline ECG is not normal, which means do exercise ECG with imaging. But let's say their baseline ECG right here, that was completely normal, then you can just do a regular exercise ECG with no imaging because you could see whatever it is that's causing the initial chest pain. Okay, we're going to do pharmacological stress testing. And I'm going to point out two high-yield things. One, know how the medications work, because sometimes they even tell you that we're given this medication, and they ask you what the changes are in the heart. So know how they work and know when to use them. And this is where we're gonna go to this table. Let's say your patient cannot exercise. Then you know it's gonna be a pharm stress test. Okay, so you have two types of pharmacological stress testers. One is going to be adenosine or dipyridamole, okay? And these are just going to dilate the coronary arteries. They're just going to increase flow to the heart. And this is very important. I've seen a question like this where they tell you, we gave the patient adenosine. What are the changes that you're looking at? Something like that. And you just need to know that the flow to the heart is increased. And what this is going to show you is that when you start exercising, there's a portion of the heart that's not getting this increased perfusion because there is a blockage in the coronary artery. So basically, when a person is at rest, they're going to have their normal flow rate to the heart, to the coronaries. The imaging is going to show you that there is normal perfusion. And as soon as the patient gets the dilation of the coronary arteries because you give them adenosine, you're going to see that a portion of the heart is not getting enough perfusion. It's not increased in perfusion. This is what this does, okay? And again, this is good for someone with a left bundle branch block, someone with a pacemaker, someone who is unable to reach target heart rate. Don't really worry about this, honestly. Look at this, and look at, we go back here, these people are getting the farm tests, okay? But be careful, because if your patient has reactive airway disease like asthma, COPD, or they're taking this medication, because again, look right here, this is another vasodilator. If they're taking a dipyramidol or theophylline, then you don't want to give them adenosine or dipyramidol because it's going to worsen their condition. Instead, you give them dobutamine. Dobutamine is going to be a beta-1 agonist, causes an increase in heart rate and contractility, and you use it for anyone with these conditions. So basically, choosing this versus this is really going to depend on your patient's health. Do they have reactive airway disease? Are they on dipyramidol for any condition? Are they on theophylline? If they are, then you just move on to this. But basically, this is how you choose what type of stress test you're supposed to do based on your patient. So before I move on, I wanted to kind of review what we just talked about a little bit. We said you do a baseline ECG, right? And then either it's going to be normal, where you do serial ECG plus troponins, or it's going to be a STEMI, like showing ST elevation, or NU, LB, BB, or just random changes. You admit, and right here, it's going to be, if it's positive changes later, you admit. But if it's negative, no changes in the ST elevation, no changes in troponins, you send for a stress test, right? And then we said that the stress test is for intermediate probability patients. And we talked about how we calculate if someone has intermediate probability or low probability or high probability. You're gonna look at the features of angina. You're gonna memorize the 3 things that you need to have from this picture. Memorize this because it's gonna help you with this. This picture is gonna help you with this. And knowing if it's typical or atypical is gonna help you to determine if you're here, here, or here. But like I said, most of the questions you're gonna be here. And so let's go down here. We are in intermediate. You're gonna do a stress test. And the type of stress test, this is gonna be something that you get asked about. This whole thing up until now, I was trying to get you to this point. You need to know what type of stress test to give to who. Like we said, here, intermediate patient. Can they exercise? Yes. Then you're gonna do an exercise. As soon as you said, can you exercise? Yes, it's gonna be exercise, stress test. However, it's gonna be either a just regular exercise or exercise with imaging, and that depends on whether or not their baseline ECG that you did at the very beginning is normal or not, okay? And we basically said what to look out for. When we say abnormal ECG, you're looking at this list right here. These are abnormal things that you don't want in your ACG when you're doing a stress test, okay? Let's go back up here. And then you can't exercise, then it's pharm. But which pharm? Are we doing the adenosine and dipyrimidol pharm, or are we doing the dobutamine pharm? Like I said, know how they work because that is testable, and then also know why we choose one over the other. Adenosine and dipyrimidol is going to be for someone who has these features. But don't give to people that have these features. You give them dobutamine. And this is, I'm going to stop right here, record another lecture, and then we're going to move on. Okay, so this is going to be part 2 of the acute coronary syndrome lecture. In the first part, the main takeaway that you need to know is how to know if your patient is intermediate probability for coronary artery disease. And again, this is someone who came in with angina pain, and we're trying to figure out if they have coronary artery disease. Once you figured out if they were intermediate probability, then you need to do a stress test next, and then we discuss how to determine what type of stress test you're going to do. And again, a lot of the questions are going to be right here. Determining who needs a stress test and what type of stress test. And then again, very high yield for you to know how they work. Because sometimes you know they're talking about a stress test, but instead of saying adenosine or dipyrimidol or dobutamine, they're just going to say something along the lines of the mechanism, like increasing perfusion to the coronary arteries, dilating the coronary arteries, or beta-1 agonists, or increasing the heart rate. So knowing the mechanism as well as who gets it and who doesn't get it is very high yield. Or not very high yield for the exam, but for this topic, this is what you need to take away. Okay, so let's say someone has stable angina. What are you going to give them? For medical therapy, the way I think about it is that they have the A, B, C, D, okay? You give them an aspirin, you give them a beta blocker, that's going to be the B, and then you give them a statin. The C is for statin. Just think of it as, a statin. It's stupid, but this is how I remember it. And you also do D for diet, and this is to remind me of lifestyle modifications. You want to tell them to quit smoking, control their diabetes, control their hypertension, because these are all risk factors for coronary artery disease. So, someone with stable angina, they get the ABCD. However, the B, the beta blockers, it's going to be, we're going to put an asterisk next to it, because even though they are a first line treatment, there are some contraindications that might not come up on questions, but that will come up in real life, or the USMLE step 2. So if beta blockers are contraindicated, you switch them out for calcium channel blockers, which are going to be the non-dihydropyrimidines, verapamil, or diltiazem. And there's another asterisk here, because if they have heart failure with reduced ejection fraction less than 40%, instead of giving them verapamil or diltiazem, you switch to amlodipine. Again, if there's contraindicated beta blockers, you give these two. But if it's contraindicated beta blockers and they have heart failure with reduced ejection fractions, you still give a calcium channel blocker. It's just going to be this one. Why? Because these two, they worsen the ejection fraction in heart failure. So we avoid them in heart failure. Know this in general, not just for angina therapy. Verapamil and diltiazem are contraindicated in heart failure with reduced ejection fraction. And sometimes you will have an angina patient who has heart failure with reduced ejection fraction. So you need to keep this in mind. So when I say contraindication to beta blockers, what are we talking about? Anyone with asthma, COPD, they have bradycardia, they have heart block, peripheral artery disease, or Raynaud's. Okay? So we're gonna move right here. We're gonna talk about, we said the B in ABCD gets replaced by verapamil or diltiazem. If there is a contraindication, we listed the contraindication here. However, if they have coexistent heart failure with reduced ejection fraction less than 40%, and they have the asthma and COPD, this means you can't give them a beta blocker and you can't give them diltiazem or verapamil. So the B will get switched to amlodipine. And I hope this makes sense. And it will make more sense when you read through the notes when you get the PDF. Okay. And let's say you give them the A, B, and C, and D. Again, asterisks here because we said this could be switched out if there is a contraindication to beta blocker or if there is a heart failure with reduced ejection fraction. Let's say you gave them all of this and they're still having angina symptoms. What are you going to do? Again, let me go back and say one thing. This is going to be daily meds, and then you give them a short acting nitro for angina episodes. So this is going to be what their daily treatment looks like, and then just in case they have an attack, they will get the short acting nitro. Okay? Let's say they have all of this and they're still having attacks, then that means you need to add a different medication. We're not switching out another medication. You first try the isosorbide mononitrate, or you can go for amlodipine. You do this first, and if that doesn't work, you switch it out for this, because this is going to be the first addition. Okay? And again, acute angina, in emergency situation, they're going to use their short-acting sublingual nitroglycerin. Okay, sometimes you are going to need to do a PCI or a CABG because they have extensive coronary disease. So when is this going to be an answer? Okay, we're going to go again to the beginning. We did an ECG. And somehow, because we calculated the probability of coronary artery disease, you got intermediate probability, you did a stress test. And stress test was positive. It showed some abnormality. What are you going to do after the stress test? You're going to do coronary angiography. Okay? This just means you're inserting a catheter into the coronary arteries to see how much is occluded, where is the occlusion. It's going to map out the coronaries. Okay, and then based on the extension of the plaque, you're going to decide if the patient gets only medical therapy. So basically what we just talked about here, they're either going to just get the ABCD part plus the nitro, or they get the ABCD plus nitro, then they get a PCI. Let's say you're giving them all these medications and they don't get better, you do a PCI or you do a CABG. Okay, coronary artery bypass graft. So okay, we're talking about how we're choosing. We already discussed this part right here. How are we going to choose PCI versus CABG? PCI is going to be anyone who has 1 to 2 vessel disease. So only 1 or 2 of the coronary arteries have occlusion, but this 1 or 2 vessels, it cannot be proximal LAD, okay? Because this is a major artery, this cannot be included. So any other 1 or 2, or the patient doesn't improve with therapy, the ABCD. If you have this or this, you do a PCI. Let's say the patient has 2 vessel disease, kind of like here, right? But it involves LAD, proximal LAD, that's a CABG because LAD is a major artery. Or if it's a 3 vessel disease. or if it's left main coronary involvement. These are indications for CABG. Just because having these involved is going to put the patient at a lot of risk for sudden cardiac arrest at some point because of an MI. So we want to kind of get ahead of it. So they do a CABG right away, and then we just do a PCI for, just 1 to 2 vessels that are not proximal LAD. So again, to summarize really quick before we move on to the next part, it's going to be, let me just delete everything. We said once you do an ECG, then you do stress, then you do coronary angiography, right? And depending on the involvement of the arteries, you either do meds only, then PCI, or CABG. Okay? And then we said the meds is going to be A, B, C, D. And then we also talked about the contraindications, when to add, when to switch. This is going to be listed here. Study it and just understand it. PCI, we said 1 to 2 vessels not involving LAD. CABG is 1 to 2 or 2+ vessels that involve LAD, or it's going to be proximal LAD actually, or if it's a 3-vessel disease, any 3 vessels, or if it's going to be the left main artery involvement, you get a CABG. Okay, so this is kind of, this summarizes stable angina. What you need to know is going to be your takeaway from this whole thing. Know these tables. Know this table, know this table, and use these two to memorize these tables. Because once you know when you're in the intermediate, then you can decide the type of stress test. So this table is very important. This table is very important. Memorize it. And know the medical therapy for stable angina. Know when to do a PCI, when to do a CABG. Okay? Before we move on from stable angina, I wanted to revisit the topic of just differentiating conditions from each other. When we learn about angina pain or a STEMI pain, sometimes they don't give you the classic description. Sometimes it's not the crushing pain with the diaphoresis, with it having radiating to the jaw. Sometimes it could just be epigastric pain and nausea. They don't mention diaphoresis, they don't mention chest pain. Sometimes not at all. Old people in general, they could have more vague symptoms, and women as well. So this is just to reiterate the point that you have to know what each condition presents like. And you can either ask me for help, you can ask AI, you can read a textbook, but just know how things are worded. I'm going to use an example here that I've noticed kind of come up on UWorld, and sometimes it also happens on the practice MBMEs, where the pain is not very clear. It's not very classic textbook description of the pain. So don't confuse angina with esophageal chest pain or costochondritis. Here I listed what each one looks like, okay? But I'm gonna let you read this when you get the PDF. We're gonna look here. This is a table that you're gonna come across in UWorld. Although that this is not really testable, use it to build the foundation for your reasoning. Coronary artery disease pain, we kind of discussed it in the silly picture that I drew. It's going to be substernal. It's precipitated by exertion or emotional stress. It improves with rest or nitroglycerin. This is atypical pain, okay? But sometimes you get the sharp stabbing pain that worsens with inspiration, or it worsens when you're lying flat, or it improves when you lean forward. Know when you're dealing with the pericarditis pain or with the pneumonia pain versus aortic dissection pain is going to be like the abrupt tearing pain radiating to the back. You're going to get hypertension, and it's going to be someone who has Marfan's or something. They're going to give you hints in question stems. Whenever, that's another hint, whenever you see someone who has multiple connective tissue complaints or history of elastic skin, easy fractures, they have a history of being diagnosed with Ehlers-Danlos or Marfan, think of, aortic dissection, think of aortic regurgitation. Whenever they mention connective tissue diseases, think of the coronary arteries, think of the aorta, think of the heart, think of the valves, because they always have issues with their hearts. This is just besides the point, kind of a tangent here. And then you have the esophageal pain. It's going to be substernal, which is why it could sometimes sound like angina pain. It also can refer to the neck. Again, when you see substernal chest pain radiating to the neck, you're going to think, oh, MI. But remember, it could be esophageal. And most of the time, they're going to tell you that it's going to be provoked by the recumbent position and it's relieved by antacids. Or sometimes they could just say it's not relieved by antacids. Pay attention to these details because it could be the difference between you getting the question right. And then my favorite type of chest pain is going to be the costochondritis pain. It's going to be pain worsening with movement and follows repetitive activity. This is going to be the easiest chest pain that you're going to see. You just give them acetaminophen and you're done. It's very low yield, but just know it exists. It comes up. So this sums up stable angina, and we're going to move to coronary artery syndrome, starting with the STEMI, which is going to be one of the highest yield things you learn in clinicals. Okay, so right now we are going to discuss STEMI and unstable angina. And these three are going to be what we refer to as acute coronary syndrome. Basically, what you are going to get in every question stem is going to be someone who presents with typical, quote-unquote, heart attack chest pain. They're going to have the substernal squeezing chest pain right here. Let me change this color. Okay, and sometimes, not always, you can get respiratory distress, like shortness of breath, bibasilar crackles, I can't say that word, bibasilar crackles, or hypoxemia, and this is because sometimes when you have an MI, you get flash pulmonary edema. So you get all of these acute pulmonary symptoms and diaphoresis. But you don't always get all of these. Sometimes it could be vague, but most of the time when they're trying to test your knowledge of the management, they're going to make it clear they're talking about an acute coronary syndrome. You're going to look at the question stem to figure out if it's a STEMI or unSTEMI or unstable angina. So basically from the question stem, just describing the pain, they're all going to sound the same, but figuring out if it's STEMI versus unSTEMI versus angina, you're gonna look at the details. So for a STEMI, the two things that you're gonna look out for, you're gonna look at ST elevations in 2+ contiguous ECG leads, or a new, keyword new, left bundle branch block. They could either say it or they could either show it. Just Google what this looks like, Google what this looks like. They're not going to be tricky with the ECG, they're not going to be tricky with the wording. Most of the time, they want you to know that they're talking about this because they just want to test your knowledge of the pharmacological workup. With unSTEMI, the difference is that there is troponin elevation, okay? But just like a STEMI, there's going to be troponins here too. But the difference is that you're not going to get the ST elevation right here. No ST elevation in nSTEMI, which is why it's called non-STEMI. You're going to get other non-specific ST changes, but it's not going to be elevation, okay? And then for unstable angina, you're going to get the classical history, how this patient was having stable angina, and then for the past 2 or 3 days, the pain started happening at rest, it's not getting relieved by nitroglycerin, and it's just going to be a picture of stable angina progressing to unstable angina because the plaque has ruptured. They're going to make it very clear as well. And one key difference here, you're not going to get troponins, you're not going to get ST elevations. So this you can tell by the features. Basically, it's a stable angina progressing to unstable. But with these two, you're going to get the ST elevation, troponins here. But then here it's like no ST elevation, but yes for troponins. And I know this is super basic. I'm pretty sure you already know this, but it's just a refresher because it helps with the questions to kind of review the basic stuff sometimes. Okay, and then of course, remember the S3. S3 is just shows you that there is volume overload because when there is a STEMI, there is a ventricular dysfunction, it's not pumping anymore, and so it gets volume overloaded and you hear S3, okay? This pops up in a lot of questions. Just remember, S3 equals volume overload. Not tiled or anything, but it does pop up in so many questions, and it's always good to know what they mean when they tell you there's S3 or S4 or whatever. Okay, so now that we kind of visited the basics, we are going to discuss two things that I think you should know. MIs, sometimes they don't look very classic in the elderly. Sometimes you could get an elderly patient with no chest pain at all, but they're having dyspnea and then they have a lot of risk factors. They have diabetes, hypertension, everything under the sun, they have it. And they have dyspnea. This is just a reminder to keep the threshold very low for suspecting acute coronary syndrome. And the other thing that you need to know, just so that you don't get confused on some conditions. Sometimes when we're talking about STEMI, remember for step 1, we had to learn how to localize a STEMI, and then you know which lead is connected to which coronary artery, and you just need to know the locations. It's very low yield for step 2 and for IM shelf, but know these leads. 2, 3, AVF. These are the inferior leads, okay? When there is an inferior infarct in this region, you get a right ventricular infarct, and it presents differently from the regular infarct, and it's treated very differently, which is why you need to know. This is not going to be high yield, but you need to know it because sometimes this is all you get for testing STEMIs. Basically, the patient is going to present with just right heart failure. Remember with the regular STEMI, when you get a regular MI, the left ventricle gets impacted, and so you get the backup of fluid into the lung, and you start getting all these respiratory symptoms. But with a right ventricular infarct, the right ventricle stops working, so the backup of fluid occurs before the right ventricle. You're going to get clear lungs, okay? But you're going to get hypotension, again, because the right ventricle is not pumping blood to the lungs, so the left ventricle is not getting any preload. And you're going to get JVD because, again, everything before the right ventricle is blocked, so all the fluid is backing up to the jugular. And you're going to get SC changes and 2, 3 AVF or the inferior leads. Okay? This is just kind of a note to keep in mind. You're most likely not going to see this, but then it does show up in some questions. I've seen it in the step 1 bank, and I've also seen it in the IM bank. Not very common, but it's there. Okay, so how do we know that the right ventricular infarct is not just tamponade? Because also tamponade has JVD, and it also has hypotension and clear lungs. So basically, a right ventricular infarct looks like a tamponade. But remember, with the tamponade, you're going to get distant or muffled heart sounds, and you're going to get tachycardia. This is high yield because RV infarct has bradycardia, because the RCA, which is supplied by basically this right here, supports the SA and AV node. So when there's an infarct here, we're losing perfusion to the SA and AV node, and you get bradycardia. That's why I'm circling tachycardia, because tamponade is going to have tachycardia. Super random, but you need to know it, because honestly, if you're not aware that this exists, seeing a right ventricular infarct, you might just think that it's tamponade and you miss the whole thing. Okay. Read this, how to differentiate right ventricular infarct from the regular left ventricular infarct. This is just for you to know and to keep in mind. Again, as I go, you might be noticing that I'm comparing how similar things present differently. How tamponade is going to present differently from a right ventricular infarct, how it's going to present differently from a left ventricular infarct. This is how you need to think, because on the exam, things can sound very similar. And if you don't learn the subtle differences between similar things, you're going to get super confused. And so every condition I study, I go to the similar conditions and I tell myself, how do I know it's tamponade and not right ventricular infarct? How do I know it's a left ventricular infarct and not a right ventricular infarct? Things like that. This is just a tip for studying in general. Okay, so this is another table comparing right versus left ventricular infarct, and this is a UWorld table, so now I'm remembering that you will get a question in UWorld testing your right ventricular infarct, so know it. This is gonna show you the right ventricular infarct pathology, so if the primary disturbance is in the right ventricle, everything is backing up and you're not getting any fluid to the lungs, which is why the wedge pressure is low. You're not getting any preload to the heart, which is why cardiac output is low. And because there is no cardiac output, the systemic vascular resistance is high, because the body sees that we're not getting enough blood out of the heart. So everything tenses up in an effort to maintain blood pressure, which is why you have the elevated SVR. Okay, so now we're going to talk about the treatment, which is the meat and potatoes of the whole thing that I'm recording today. So when you get a STEMI or unSTEMI, there's an E here, or unstable angina, you have two levels of treatment. You have acute and you have the post-acute. I just made this word up. So this is the long-term treatment. Okay, they're gonna be very, very similar. All of these are gonna be very, very similar, but there are subtle differences that you have to know. Okay, so let's start with a STEMI. A STEMI, or ST elevation myocardial infarction, is gonna be an elevation of 1 or more millimeter in 2+ contiguous leads. This is just super technical. You never have to measure how high the elevation is or the number of the leads. On exam, they're going to make it very obvious that it's a ST elevation. They're going to give you an ECG strip with classical presentation, and it's going to be super elevated ST segments in many, many leads, and it's going to be right in your face and you can't miss it. So this is just technical, know it, honestly, but like nobody really cares on the real exam. But sometimes they just show you a left bundle branch block, new one. They could either say it in the question stem or they could show it. Again, look up a picture of this. It's super easy to spot. Okay, so we do the ECG, we order the troponins. But because we can spot this from the presentation, and we said we start aspirin and nitroglycerin super early on, we just start the acute treatment. And when I studied it, I followed this mnemonic because I made it up myself before I knew that the Monabash existed. So you could use this one or this one. It's up to you. It's the same thing. I added the Monabash one here for your reference, but then for my notes, I'm using my own just because I learned this way before I knew this existed. So the initial treatment for a STEMI is going to be Nacobus, okay? And this is going to be the same for STEMI, unSTEMI, and unstable angina. So this is a pretty nice setup because you're learning all three, okay? The N stands for nitroglycerin. Again, know why you're giving certain medications, because sometimes they could just tell you, oh, the patient still has pain, the patient has hypotension, the patient has hypertension, what are we adding, what are we doing? So know why you're giving nitroglycerin. Nitroglycerin is to reduce pain and reduces preload. If you give nitroglycerin, you give everything else, and the patient is in so much pain still, you give them morphine, okay? And yeah, honestly, that would be the next step. And you're going to see a diagram down below from your world. Tells you that if there's extreme pain, give morphine. But we finished the N. So now we move on to A, which is aspirin. Again, N and A, remember the very first step when I told you we do an ECG, stent troponins, and then we give nitroglycerin and aspirin. These are the very first two things you give. Sometimes these are even given in the ambulance as they're bringing the patient. But just in case, add these two first, okay? The C is for clopidogrel, okay? And the O is for oxygen, only if the SaO2 is less than 90%. If the vitals show like 94%, don't give oxygen, you know, but if it's below 90, give oxygen. And the B is for beta blocker. And again, avoid if there's hypotension, if there's heart block, or acute heart failure, or bradycardia. Avoid, okay? And then you add an anticoagulant. And this is one of the subtle differences that you need to know when, like, are you given unfractionated heparin or low molecular weight heparin? Sometimes they're nice and they just put heparin so you don't have to choose. But if we're going for PCI, okay, let me backtrack and just go here. So we said that acutely give Nacobus or Monabash, whatever you're gonna use, okay? After we give the list of medication and you're given all of them, you do reperfusion. And it's either PCI or, I'm blanking out, a PCI or a fibrinolysis, okay? Whether you're going with this or this after Nacobus determines if you give this or this for this A portion, okay? If you are going for PCI, which is going to be your goal, you give unfractionated heparin. But if you can't do a PCI, let's say you go to a hospital and they're not capable of doing a PCI, and you're not able to get to a hospital that does PCI, your only option going to be is to do the second best thing, which is fibrinolysis. Then for this A portion, you give low molecular weight heparin, okay? So right here I said, depending on if we're doing a PCI fibrinolysis. So again, we're doing acute medication. You give this Nacobus or Monabash, whichever you want to use. After you give all of these, you're going to do reperfusion, and there's two ways to reperfuse, PCI or fibrinolysis. Our main goal is to do a PCI, okay? But sometimes we do fibrinolysis, okay? We're gonna go over why we do that sometimes. But let's move on. We did the Nacoba, and then we do S, a statin, you give a high dose, atorvastatin. And then if you give all of these and somehow the patient has bibasilar crackles showing that there is pulmonary edema, you add IV furosemide, okay? And here is a note that you should keep in mind, because earlier I said a right ventricular infarct is treated very differently from a left ventricular infarct, because with a left ventricular infarct, which is the regular variety of infarction, a STEMI. We don't give fluids. They're actually overloaded. We're trying to get rid of fluid right here. So fluid restriction is very important here in the left ventricular one. But with the right ventricular one, which is why you need to be able to recognize it if it comes up, the treatment is actually for fluid resuscitation. So we give them fluids. It's totally the opposite, which is why I mentioned it, because you need to know it. Even if it doesn't come up a lot, it could come up in rotations, it could come up in real life, and it could be one random questions on your test. So we covered that, okay? We did the Nakoba's thing, or Monabash, whichever you want to use, and then afterwards we have to reperfuse either A, PCI, or B, fibrinolysis. How do we choose? Okay, this is going to be very, very important, okay? Here, read this. This is the Monabash thing, Nakoba's, whatever you want to call it, 2 tables from UWorld. Just memorize it, honestly, just memorize it. You're given all of this. Here is an example of a STEMI right here, okay? And here is the Nakoba's list I went through. And then here, if there's persistent pain or hypertension, we give extra IV nitroglycerin. If there is severe pain, we give IV morphine. If there is unstable sinus bradycardia, you give atropine. And if there is pulmonary edema, you give furosemide. These are just extra These are extra sprinkles over the standard Monabash or Nakoba's list that we just went through. So you give the Monabash, okay, or Nakoba's. I'm biased against it for this one, not against it. And then if the patient meets any of these things, you can add one of these. So these are not part of the standard treatment. These are just an extra something, okay? So you add the medications, and now we have to reperfuse. And we said we either have to do a PCI or thrombolysis, okay? And now we're gonna see how they're gonna decide if it's PCI or thrombolysis. Our main goal is to do a PCI right here. And you can do it if you are able to do it within 90 minutes of arrival to the hospital, or if your hospital can't do a PCI and you want to transfer, it must be within 120 minutes, okay? So if it meets one of these timelines, either at your hospital or some other hospital nearby, you do a PCI, okay? If your hospital doesn't do a PCI and the nearest hospital that can do a PCI is like 3 hours away, then you don't have an option. You have to do fibrinolysis, okay? And again, this is the reperfusion here is only for STEMI. The Nakoba's thing that we just discussed, the list of medications, this is for all of them. STEMI, and unstable angina. But the reperfusion thing that we're talking about right now is only for STEMI, because STEMI and unstable angina are going to have 2 different things, okay? So before we do the PCI, you have to give them DAPT. And DAPT was part of the Monabash, to be honest. That was the aspirin and the clopidogrel. Okay? Make sure that they're part of the list you're giving them. They're required before PCI. Okay? And you have to give unfractionated heparin. Remember, PCI, unfractionated heparin, fibrinolysis, you give low weight molecular heparin. Okay? So here we're doing DAPT, which is aspirin and clopidogrel. Again, that's part of the Monabash. And then the unfractionated heparin, which is also part of the Monabash, but make sure that you're choosing unfractionated heparin, okay? So you do the PCI. Once you do the PCI, we start chronic management. These are a list of medications that they take home. We're going to go over this later, But you do PCI, then you go to chronic management and we're done. If PCI is not possible, you do fibrinolysis with alteplase, and then we go back to chronic management. So basically, we do the monobash, then reperfusion with either this or this, and after we do one or the other, we start chronic treatment. So the fibrinolysis, we do it with alteplase, okay? And again, it's recommended for STEMI, arriving within 12 hours, who cannot undergo PCI, okay? So fibrinolysis, what you do is that you give the DAPT that we talked about, exactly like the one here. You give them that. You also give them low weight molecular heparin instead of the unfractionated heparin, right? And alteplase. So you give them 3 meds to fibrinolyze them, okay? And there are absolute contraindications to fibrinolysis. I'm pretty sure I listed them here. Okay, right here. Okay, the absolute contraindications to anticoagulation are these. Memorize them. I just needed to mention that because I feel like I didn't mention it. Okay. No PCI complications, because as you remember, which is also high yield, know the post-MI complications, okay? I could make a separate video for this if you want, but these are straightforward. Just know what they look like and when they happen. They're not going to get tricky with the complications. But because we know there are some complications that can occur within the first week or two post-MI, just know PCI also has some complications that can happen, which is basically stent thrombosis. So what you need to know, and I can go through this in the second video, know how to differentiate post-MI complications from PCI complications. And right here, I kind of talked about it in this paragraph. Read this on your own and ask if you have any things that you need to be, anything that you're confused on, I can explain. I just want to get to the more important part. But just know that post-MI complications and can be like either the, mitral regurgitation, ventricular septal defect thing, or they could be a PCI stent thrombosis. No, that's a thing. Sometimes they try to test you to see if you know how to differentiate it. Okay. It doesn't mention it here, but we'll go through it in a little bit. Okay, so on STEMI and unstable angina, we do the same thing. We give them the NACOBA's list for both. Again, you could just say mono bash. You could just do that, okay? Their acute treatment is that. However, where this is going to be different, okay, so far we said STEMI, unSTEMI, and unstable angina, they all get Mona Bash for initial stabilization. Where they're going to be different is the reperfusion step, because under no circumstances are you going to do fibrinolysis. It's just not going to happen for these guys. And PCI is only if it's severe. So most of your patients who have NSTEMI or unstable angina, they're going to get the Monabash, and then they're going to move on to the chronic treatment, just like the chronic treatment for a STEMI. Sometimes if it's really, really bad, you'll do a PCI, but most of the time they don't get a PCI or fibrinolysis, okay? So what makes NSTEMI and unstable angina so bad that they need a PCI like STEMI? Just have these features: hemodynamic instability, like if they're in shock, if they have congestive heart failure or ventricular arrhythmia or structural abnormalities. These are just really sick people with dangerous features. Reduced ejection fraction, okay? But if you don't have any of these, if it's a stable patient who just happened to have some unstable angina pain and they're fine now after you give them the Monabash, then you don't do PCI, and definitely no fibrinolysis. Okay? And then after you discharge STEMI and STEMI and STEMI patient, they all get the same long-term therapy, which we're gonna do. We're gonna make it a little bit easier. The way I remember the long-term treatment for all of them is gonna be A, B, C, D, okay? Aspirin, or actually ACE inhibitor, A or B, or this is an or, okay? Beta blocker. C for statin, and DAPT. And what is DAPT? We said again, it's aspirin plus clopidogrel. And this, you only continue it for 12 months and then you stop. But everything else is for life, okay? And you can add an MRA, which is the mineralo, how do I write this? Mineralocorticosteroid receptor blocker, receptor agonist. Am I writing this right? You're gonna know what I mean. Okay, so MRA, which is gonna be for ejection fraction less than 40%. So these are patients who develop heart failure or potassium less than 5, creatinine less than 2.5 for men, or less than 2 for women. They must have this in order to be able to add a aldosterone antagonist, which is what I was trying to say. Now I remember. Aldosterone. Like spironolactone or eplerenone. My notes are going to be, the typed up notes are going to be a lot better. Okay, so you add this only if, they have low ejection fraction, they have heart failure or diabetes, or, they have these features as well. These, just to make sure that they can handle it. You can't have super high potassium and super high creatinine and give them spironolactone or eplerenone. So these are just going to be the long-term treatments for both. So I'm going to do a quick summary just so we kind of wrap it up. We said that for all three, STEMI and STEMI, unstable angina, you give them Monabash, or if you want to use my mnemonic, or what do you call it? I'm going to call it a mnemonic because, to be honest, I don't remember. If you want to use Monabash, or you can use Nacobas. Once you give them all of this, you want to reperfuse the heart. You want to reopen up the blockage. We said you do a PCI. Let's go here. Nacobas to stabilize. Then reperfuse, which is either via PCI or via fibrinolysis. Once this is done, And again, remember this step only for STEMI. Okay? Or really bad STEMI or unstable angina. So, you know, when I said the indications for PCI, if you have an STEMI or unstable angina, so you don't reperfuse everybody who has unstable angina or STEMI, but you do reperfuse all the regular STEMIs, okay? Once you reperfuse, you go to chronic therapy, which is gonna be the A, B, C, D that we talked about, and this is DAPT, and this is statin, and this is beta blocker, and this is ACE inhibitor or ARB, plus or minus MRA, which is spironolactone or eplerenone. Okay, if they have an ejection fraction less than 40, or they have diabetes or heart failure, and they must have potassium less than 5, creatinine less than 2.5 for men, and creatinine less than 2 for women. Okay?